Okay, I'll present, but sir, this was not my case. I'll start reading it up. It's fine. This case is of a
Sorry,
female,
I
40
think,
years old.
wait, 1 minute, 1 minute. This is not,
Okay.
this one was your case?
Yes, yes.
Okay.
All right. So this is a 39 years old male, known case of acute myeloid leukemia, and current KPS is 90. He had presented with complaints of dysphagia and forgetfulness for the past 3 weeks. Once this patient was residing outside Karachi, therefore they directly landed up in the emergency, and therefore at that point in time, because he was not drowsy or his GCS was not, therefore we decided to proceed directly with an MRI beam with contrast, which was done on 5th of May 2024. Can we see the scan? So these are the pre-operative images. These are the T2-weighted images that were done here at AKU, where we can see you can see the left frontal lesion with surrounding edema, and which is causing mass effect and effacement of the ipsilateral lateral ventricle.
And we can ask Dr. Shumaila also to give her opinion, and I think if we can Dr. Shayan. Yeah, no problem. Dr. Shumaila, आप मुझे बताइएगा कौन से, if we can just go down.
Maybe we can start from the first series. It's fine. It's, I think, the first slide of images. So these are T2 weighted axial images in which we can appreciate that there is a focal abnormal mass lesion in the left frontal region with extensive vasogenic edema. And here I would like to share with the neurosurgery residents, especially, that there's a difference between vasogenic and cytotoxic edema. So any edema which is lying as a finger-like projection in the white matter is a vasogenic edema, and it is more associated with masses, abscesses, etc. Whereas cytotoxic edema is a wedge-shaped edema which involves both gray and white matter. So these are the areas of finger-like white matter signals surrounding the mass lesion, and these are areas of which this is vasogenic edema surrounding the mass lesion. The lesion is crossing through the genu of corpus callosum. It has few T2 hyperintense central signals, which may represent areas of internal necrosis. It is relatively hypo to iso-intense on T2 weighted images. So it is causing significant effacement of ipsilateral lateral ventricle, and there is mass effect and subfacine herniation and midline shift associated with this. So now we can go to the next slide. So these are post-gadolinium T1 weighted images, and we can see that the mass is showing significant post-contrast enhancement. There's an adjacent, there are adjacent 1 to 2 areas of similar enhancement characteristics lateral to the larger mass lesion. The above row is of pre-contrast images, and the lower row is of the post-gadolinium images. So we can compare that the mass is showing significant enhancement. There are few central non-enhancing areas which were probably T2 hyperintense, which I'm assuming are areas of internal necrosis. So similar characteristics are appreciated in the next slide, and we can see that the enhancing component is crossing the midline through the corpus callosum. It's genu and proximal half of body of the corpus callosum probably. These are FLAIR coronal images, and in FLAIR coronal images, the findings which were seen on T2 weighted images, they are redemonstrated. Only the normal fluid is suppressed, and we can see that there is extensive vasogenic pathological edema surrounding the lesion. And then the lesion is crossing the midline through corpus callosum. It is better depicted on FLAIR images. There is midline shift, there is mass effect, there is effacement of ventricle. All the findings are redemonstrated. On the sagittal images, we can again appreciate that if you look at the first and second image in the first row, you can see that this is lying in the, this is crossing the corpus callosum. It is best seen on these. The crossing of the lesion through the midline is best seen on sagittal images, and rest of the findings are the same. So I was just interested in looking at the susceptibility and diffusion images which were not provided in these slides. You can either share the or Shayan can share the findings if it is a case from your center.
Right. Dr. Anam, can you please upload the DW? Dr. Shayan, meanwhile, if you want to add something or your opinion. जी जी आपकी आवाज आ रही अनम आप दिखा दें
सर मैं लोड कर रही हूँ एक्चुअली
ओके आप मुझे बताइएगा मैं स्टॉप शेयर करूंगा
ओके
अस्सलाम वालेकुम डॉक्टर अदनान
वालेकुम अस्सलाम
So far, the images we have seen, it appears to be a primary aggressive neoplastic lesion of a high-grade neoplastic lesion of the brain parenchyma, glioblastoma, aggressive neoplastic lesion with probably 1 to 2 satellite nodules, or maybe they are connected through the edema at subcellular level. But this appears to be an aggressive neoplastic lesion. Iske differentials maybe even we can consider lymphoma, but the central areas of necrosis, if they show susceptibility, that is more in favor of GBM. अभी तक जो images देखे हैं उसके मुताबिक तो मुझे यही लग रहा है. That is why I wanted to look at susceptibility and diffusion.
I'm basically trying to run it on a system computer, and unfortunately my laptop has run out of storage. But I think it should be.
It's okay. We can.
No problem.
It's okay. We can carry on with our discussion.
अनम आप इसकी हिस्टोपैथ प्लीज बता दें
Right. So the histopath that was later on discussed, it showed that this lesion was primarily this lesion primarily originated from had a myeloid origin, and it was discussed that it was invaded by a myeloid sarcoma, which shows that this was primarily a relapse of his previous illness.
So relapse of
his previous illness, because he was a known case of acute myeloid leukemia.
Right. Okay. ठीक है. Okay, thank you. So that Dr. Mazhar, आपकी opinion sir अब इसमें हम
अब इसकी जो if this is a rare AML में CNS में ये माइलॉइड सार्कोमा बन सकते हैं और ये बॉडी में और भी बनते हैं जिसको क्लोरोमा कहते हैं. So normally these are chemosensitive and radiation sensitive tumors. इनकी resection वगैरह हो गई ये सारी के नहीं? या biopsy?
We just did a biopsy.
And what came out of it?
This is what the histopathology says that it was involved by myeloid sarcoma.
Sarcoma, ठीक है. Which is a rare complication of AML ये है. So I think इसमें both chemo and radiation has a role in that.
Sir, sorry, आपकी आवाज. Chemo radiation के लिए हम भेजेंगे, right? आपके ना बैकग्राउंड में बहुत ज्यादा नॉइज है. So एक मिनट सर. So Dr. Mazhar, आपने कीमो रेडिएशन सजेस्ट की है, right?
No, because AML में ये it is not a sarcoma as such. It is one of the complication of AML. So these are also known as chloromas, and they are radiation and chemosensitive tumors.
Okay, ठीक है. Thank you. Doctor,
I'm sorry now I've been able to put up the sequence.
ठीक है. Dr. Shumaila, आप हमें बताइएगा if you want to go some specific, and can you see on your screen?
Yes, I can. Can you scroll once again, please?
एनम एक दफा फिर आप स्क्रॉल.
I mean, yes, it is going more in favor of some, because we have a history of AML. So lymphoma, leukemia, something like that, because the T2 weighted signals are also, iso to hypointense, and there is again different restriction which shows that there is dense cell packing and there's no susceptibility. So
Right.
in the light of the history, yes, we can go for a lymphoproliferative kind of thing going on, deposit
Okay.
from the same primary. Yeah.
Okay. Okay. Thank you.
So
Dr.
there is
Adnan. जी डॉक्टर मजहर सॉरी. अच्छा डॉक्टर रियाज बात करना जी. डॉक्टर रियाज सर प्लीज बताएं.
So there is no need for the surgery in these cases, and we as a neurosurgeons have no experience of the features and everything about the systemic neoplastic lesion, like this is the myeloid leukemia, and this is the area where everyone think about to take a biopsy, either stereotactic or a very safe biopsy. And if this is the case, that as Dr. Mazhar says, these are the radiosensitive and chemosensitive. So I think there is no need for the surgery. But up to how extent they can be responsive and symptom free with the chemo and the radio.
Okay. ये डॉक्टर मजहर सर आई थिंक
this is a quite young patient.
Because I have not come across treating such a case where normally a case like this would go to hematologist. And
Right.
what literature says that it is quite chemosensitive disease, and even in the lesion in the brain would not need a very high dose of radiation. But normally lymphomas and Hodgkin's or non-Hodgkin lymphoma with lesion in the brain do respond to radiation very effectively with almost 24 gray or maximum 30 gray. So I'm sure that radiation is करेगा, लेकिन I think first they have to give this patient chemotherapy and then do follow-up MRIs and treat the brain. Then the radiation fields depend. I would rather treat the whole brain, and because there are chances of disease or cells coming lying anywhere in the brain. So that would be my for radiation point of view. I would treat the brain after the patient has been given chemotherapy and assess the response.
I have one question again. As a neurosurgeon, we find such type of the cases, a single lesion in the brain, and we neurosurgeons always think about this as a intraaxial lesion at the glioma. So, if we don't know about the previous history and there is no any clear previous history of the myeloid leukemia, so every patient should be sent for the such type of the investigations to rule out such type of the problems like the myeloid leukemia, because most of the time these things are hidden.
वो तो आपको ब्लड काउंट से पता चल जाएगा ना, जब when you are planning a surgery आप उनके CBC वगैरह और ये चीजें तो करोगे, उससे आपको अगर कोई abnormal पिक्चर आती है तो then definitely you will investigate it further. अगर वो it's the first time coming to you के उनके, क्योंकि a normal patient with the brain other gliomas or astrocytomas उनके white cell count और CBCs वो normal होते हैं. So AML में there would be abnormal counts, and then that would put you into a पिक्चर के अब आप इस मरीज को आगे इन्वेस्टिगेट करके इसके बायोप्सी करोगे.
Okay, thank you.
डॉक्टर अदनान सर आपका पॉइंट ऑफ व्यू प्लीज. डॉक्टर अदनान इज हियर. ठीक है. So we can go to the next case. Any other questions, comments from our?
Yeah, I just wanted to know, like, how are the cell counts of this patient before neuronavigation guided biopsy?
सॉरी डॉक्टर शान, थोड़ी सी आपकी आवाज में वो थी डिस्टॉर्शन, क्या कह रही हैं आप? हाउ वाज द पेशेंट?
What was the cell count of this patient?
सेल काउंट?
Cell
Actually,
count, yes.
this patient was already diagnosed, so maybe this patient has already received chemotherapy for AML in the past.
So must be in remission then came to us with CNS symptoms probably.
Yes, that's true, because when he came, his counts were pretty much normal. His CLC was 9.6 and his dose was 72.5. Lymphocyte count was also 20, and yes, he had previously received.
अनम, आपकी आवाज साफ नहीं आ रही, थोड़ा सा और माइक को करीब करके बात करें प्लीज।
जी, अभी आ रही है सर?
हाँ हाँ, बेहतर है।
जी, मैं यही कह रही हूँ that Dr. Shan is right that he had received chemotherapy previously before he had presented to us in the ER. So his cell counts were normal when we saw him in the ER. His HP was 15.2, his TLC count was 99.6, and neutrals were 72.5. Lymphocytes were also within normal.
But this patient probably has received chemotherapy. अगर आप इसके counts उस वक्त देखें जब ये AML diagnose हुआ था, उस वक्त इनके counts normal नहीं होंगे. So the question of the question of neurosurgeon was कि if a patient undiagnosed AML come to them, how would they know? तो मैंने उनको यही कहा था कि अगर AML का केस आपके पास पहली दफा है और has not been treated by a hemato-oncologist, तो उनके the first counts और bone marrow उनके abnormal cells आपको abnormal नजर आएंगे. There will be very high white cell counts और neutrophil counts or whatever जो उसकी picture होती है. लेकिन इस केस में चूंकि it was already a diagnosed case, so already chemotherapy वगैरह लग चुकी है, and this is a rare complication के brain में वो चीज आ गई है, तो इसमें जरा picture different होगी. इसमें जो न्यूरोसर्जन के पास अब जब ये गया बायोप्सी के लिए, तो most probably because patient has received chemo whatever, तो उनके counts maybe peripheral counts normal हो.
Yes, sir, you're right, because previously back in 21 when he was diagnosed, his blast count was 90 and his TLC, like overall TLC count was 30.3.
हाँ, यही मैं कह रहा हूँ कि अगर इस तरह का केस न्यूरोसर्जन के पास आता है तो वो डेफिनेटली सर्जरी से पहले या बायोप्सी से पहले उनकी ब्लड पिक्चर तो देखेंगे. तो वही क्वेश्चन था न्यूरोसर्जन का कि हमें कैसे पता चलेगा कि ये मैंने उनको यही कहा था कि जब आप एक अनडायग्नोस्ड केस आपके पास आया और आपने उनके काउंट्स किए, तो वो काउंट्स ही आपको कुछ बताएंगे कि समथिंग इज रॉन्ग समवेयर एल्स.
Right. So this patient had received chemotherapy, right? And that was the point.
जी sir, बिल्कुल.
Thank you. So we can move to the next case. And now
I just have a question. So this lesion, now that it is in the brain, it is responsive. It is still responsive to both chemo and radiation.
Yeah, I think you should take hemato-oncologists on board along with radiation oncologists के लिए उनके लिम्फोमा MDT में या जो ब्लड इनके leukemia का अगर कोई इनका ट्यूमर बोर्ड होता है तो उसमें इस केस को ले जाएं, and then from there the hemato-oncologist and the radiation oncologist will take up the case.
Thank you, sir.
Thank you, sir.
Okay, Alicia or Zainab, who is presenting this? Zainab, आप कर रही हैं present?
जी सर, आई एम हियर.
अच्छा, अलीशा आप जी. अलीशा, please.
Sir, she is a 40-year-old female of KPS 80, known case of NF2, diagnosed in 2016. Presented with headache, vertigo, gait disturbance since March 2024. MRI brain and whole spine done in 2023, where it showed multiple enhancing lesions, supra and infratentorially, involving brain and whole spine, cervical, dorsal, and lumbar. She has history of headache and left-sided weakness, left-sided hearing loss in 2016 when her first MRI was done, which showed right parieto-occipital lesion with mass effect and left CP angle lesion. She underwent resection of right parietal lesion in 2016, which was meningioma high grade, low-grade meningioma, yani grade 1 meningioma. She underwent whole spine MRI, which revealed multiple lesions in cervical and dorsal spine. No further treatment was advised after that. In November 2023, she had relapse of headache, vertigo, gait disturbance, neck pain, and right-sided hearing loss. She underwent cyberknife 5 sessions. After which she presented to these symptoms with us. There was no symptomatic improvement.
Okay.
So these are her MRI from July 2023, which are pre-cyberknife basically, which are showing multiple hyperdense lesion in the supratentorial region and as well as the infratentorial.
डॉक्टर शुमाइला आप प्लीज थोड़ा सा हमें
Yes, I agree. There are multiple focal abnormal signal intensity areas. The first row is T2 weighted axial images. The second row is also from T2 weighted axial images. And here we can appreciate that these are all extra axial, and how we decide that the lesions are extra axial. There are certain signs, and one of the signs is that you can see a CSF cleft around the lesion. It is broad based towards the periphery. It is causing buckling of gray white matter. So all these features are present. The lesion, the supratentorial and infratentorial lesions, most of these are meningiomas. We can call that this is meningiomatosis along the forks. And in the left CP angle, we can see that there is an abnormal signal intensity area which is causing widening of the internal auditory canal and showing intracanalicular extension. It appears like an ice stream. It is giving an ice stream on cone sign. So this lesion has a different feature as compared to rest of the lesions, and this is left CP angle schwannoma. All of these lesions are showing intense homogeneous post-contrast enhancement. The lesion, the first row is pre-contrast T1 weighted axial images, and the second row is post-contrast. And if you look at the last image in the second row, you can see that the intracanalicular component is also showing enhancement on the left side. So these are multiple meningiomas, and then there is a CP angle schwannoma. I cannot see an ependymoma, which is also a part of spectrum of NF2, but in these images, I cannot appreciate that. And on sagittal images, we have the same features. There's a meningioma at the cervicomedullary junction as well, and the proximal part of cervical spinal cord posterior to C2, we can again see an enhancing lesion. Still, I cannot appreciate an ependymoma, but I can see multiple meningiomatosis along the forks, and then at the cervicomedullary junction. So, and then from the sagittal images, post-contrast images from the cervical and dorsal spine, again, there are multiple enhancing lesions seen along the surface of the cord, suggestive of meningiomas.
Okay, thank you.
These were the post-cyberknife. Post-cyberknife scan.
Right. So, Dr. Shayan, do you want to add something? Sorry, मैंने आपसे ये share नहीं किया हुआ था. Really sorry for that.
No, not at all. I've seen all these cases before. It's perfectly fine. Actually, I don't have to add much, but we can also see some enhancement to the right-sided vestibulocochlear nerve complex as well. So that is bilateral acoustic schwannomas are favoring NF2. So, and in the spinal images, you can see the central lesions within the cord are ependymomas. If you can put up that spinal images.
Right.
So the one in the cervical region is from at least 2 or 3, you can see that there is some enhancement within the central canal. So these correspond to the ependymomas.
Dr. Mazhar, before you leave, can we ask your opinion on this?
इस केस में इन्होंने एक तो इसका वो कर लिया था stereotactic. I think that's the only जो इसमें unfortunately this patient has multiple suprainfratentorial meningiomas and in the spine as well. So it's very difficult to treat this patient either surgically or with whole brain radiation because it needs a high dose of radiation, and we can't actually cure these meningiomas like this. So most unfortunately, she would be whenever she becomes symptomatic from any of these lesions, then that can be given stereotactic radiosurgery or gamma knife. That's it. I don't think surgery or
Right.
The
So
whole
I think
brain
we
radiation
go
is
for,
done.
in these cases, we go for the palliation, something like that,
Yeah,
right?
it's a palliation, and it depends on from which lesion she becomes symptomatic, and then that lesion can be treated. Few lesions like in the brain, 3 to 4, 5 lesions can be treated still tactically, depending case कौन सा इसमें symptomatic होता है. So she is not curative case anyway, unfortunately.
Right, right. Thank you.
So, Dr. Mazhar, is there any role of immunotherapy in these patients?
Sorry.
Is there any role of immune therapy? Dr. Shayan is asking.
Oh, I am not sure कि इसमें immunotherapy का कोई रोल होगा, लेकिन one can look into it अगर कोई papers इस तरह हो या literature में, but this is the first case that I've seen with multiple when you presented the case, I thought कि ये कोई metastatic cancer है जिसमें suprainflammatory lesion, लेकिन when it came out to meningioma, this was the first case that I've seen in my professional life, like in last 40 years, with so many meningiomas in the brain. So I'm not sure कि इसमें कोई immunotherapy का कोई definitive role ऐसा कोई होगा, लेकिन one can search the literature.
सर इसमें लिटरेचर में ना बेवेसिजमैब का बहुत प्रॉमिसिंग रोल कहा हुआ है काफी जगहों पे.
वही मैं
बेवेसिजमैब
कह
का
रहा हूँ कि
टारगेटेड कीमो है जिसमें वो उसका जो पाथवे होता है पूरा इनके प्रोटीन्स के एक्ट करने का, उसमें कुछ टारगेटेड उन्होंने थेरेपीज बनाई हैं, लेकिन वो सब अभी ट्रायल के अंदर ही हैं.
वही
जो
मैं
आप
कह
कह
रहा हूँ ना कि दिस इज ऑल ट्रायल्स. तो जो अगर इस तरह का कोई पेपर और कोई ट्रायल हो तो वो बंदा कर सकता है, लेकिन कोई स्टैंडर्ड ऑफ ट्रीटमेंट अभी तक नहीं है इसकी इस तरीके से.
सर मैंने इसको उनसे डॉक्टर अदनान जब्बार होते हैं उनसे भी डिस्कस किया था.
जी
सो
जी.
ही अगर इनमें कोई इंक्रीजिंग साइज हो, यानी कि कोई एक सिम्टोमेटिक लीजन हो जिसका साइज इंक्रीज हो रहा हो और हम बार बार सर्जिकल इंटरवेंशन नहीं कर सकते हो, तो हम उसमें बेवेसिजमैब का ट्रायल दे सकते हैं और फिर
वही मैं
देख
कह
सकते
रहा हूँ कि ट्रायल के बेसिस पे आप डेफिनेटली वो कर सकते हो. वो तो मैं भी कह रहा हूँ कि अगर इस तरह की ट्रायल्स डेफिनेटली हुई होंगी और आप लिटरेचर सर्च करके उनको ट्रायल पे डाल सकते हैं. सर्जरी तो आई थिंक मल्टीपल लीजन है, आप कौन कौन सी रिमूव करोगे. और द ओनली ऑप्शन जैसे मैंने कहा कि इफ शी बिकम सिम्टोमेटिक फ्रॉम अ लीजन दैट ग्रोज, देन वन कैन डू एसआरएस इन दैट वन टू रिलीव हर सिम्टम्स, एंड दैट्स आल्सो पैलिएटिव इंटेंट हो गया ना. meningioma which cannot be excised, radiation is not going to cure it, it's just going to palliate it.
So yes, sir. So I think
And similar is the immunotherapy. अगर इसमें कोई trials चल रही है तो that is also would be
still it's not
palliative.
curative, right, sir?
It's not
Yeah.
curative. That's the main
That's your
point.
point. Yes, yes, yes. True. Unfortunately. Any other point? Any other question? Dr. Riaz, आपका कोई point पे बात?
No, I think this was a very interesting case, and we have operated such type of the case of young boy who has the multiple spinal neurofibromas associated with the intra-abdominal problems. So we operated him, and I think this is a 10 to 12 years back. And we operated first off from cervical, then he improved, then again he became paraplegic, then the dorsal, and even lastly he came with the abdominal problems. So this is a very complex type of the tumors, complex type of the cases. I don't think so we can do much surgically or with the radiation therapy to the patients.
Right, right. True. Thank you. Okay.
Okay, so I will leave and I'll inshallah see you
Sir,
next
thank
time.
you so much. Sir, thank you
Thank
so
you
much.
so much. Thank you. God bless you. Bye.
Okay, Hassan. Again,
Yes.
thanks to you and keep up this work. You are doing very well by this organizing these type of the meetings, and we like it. I always compel my students to come and join with Dr. Hassan.
Thank you, sir. And we look forward to cases also from your center.
Yes, I have